I'd like to welcome now to the podium Melina Vassiliou from McGill. Melina has in many ways been the brains of the technical skill development aspect of the FES project. She has put in the space of a couple years truly a career's amount of work into helping us validate the technical skill modules, which is such an important part of this curriculum. And Melina, as Matt has just alluded to, has done a great deal of research along with Jerry Freed and Leanne Feldman and others in their group at McGill related to skills development in the laparoscopic setting. And she's going to talk to us now about transference of skills to the clinical setting. Is this the holy grail, or is it really a reality? Melina?
Good morning, everyone, and thanks for the introduction and for the invitation. So this talk is really going to focus on some of the data out there for transfers of skills, specifically as it relates to flexible endoscopy. And unfortunately, a lot of the people who've done these studies, or a lot of these studies, didn't hear Matt's talk, unfortunately, before they did them, so the quality is quite variable, and we'll talk about that. My disclosures are only that we get support for our research in an unrestricted way from Covidian, but that won't really affect anything I'll speak about today. So we'll talk really about some of the challenges of these transferability trials and how really it's the problems that this creates for us in interpreting the data. And then I'll look at some of the studies that are out there for sigmoidoscopy, colonoscopy, and upper GI endoscopy. And you'll see these little green and red boxes up on the top of the slides where I kind of give an interpretation or a colorful interpretation where the green ones show that there's some benefit and the red shows there's no benefit. And sort of where do we go from here? So certainly there is a lot of evidence supporting the fact that simulation can transfer to the clinical environment. We know that simulator practice improves performance on the simulator. That's pretty straightforward. And most of this data actually relates to laparoscopic surgery skills. There's very little of it for endoscopy. But we know that simulator practice improves performance on live animal models as well. And the transfer is new. A recent review, a systematic review of transferability trials, there was about 11 of them, really does show that there is evidence to support transfer of those skills, both using physical simulators and virtual reality interfaces. And the reason for this is that making this link is really hard to do because we're dealing with having to do our jobs first, which is needing to put the patient and the care of the patient first. Some of the challenges that the clinical environment has that we can't control what comes through the door, we can't control what happens sometimes. We need to balance sort of getting approval of ethical approval. We need to balance biases related to rating and training status. There's issues of scheduling and rotations of residents and just real life that gets in the way of trying to do some of these studies. And of course, variables related to patients that are really hard to control. Variables related to surgeon or endoscopist, teaching styles, levels of comfort when they need to take over. And of course, getting residents also to comply with the curriculum that we want them to do in the simulator. So all of these things really make transferability trials hard to do. And that's not even including some of these other aspects related to study design, so whether or not, is it appropriately powered? Do you have enough people at your institution? Do you have to go and do a multi-center trial to get additional people to comply? Did you do baseline testing? What kind of measures did you use? How did you train people? Did you do it in a distributed fashion? Did you do it in a one-shot deal? For how many hours? Up to what level? Was it proficiency-based? What was the curriculum? How did you decide what to do with the curriculum? There's so many variables that basically make it such that all the studies that have been done are really hard to interpret as a group because everything is different. So it's really, they use different simulators, they use different training paradigms, different curricula, and up to different endpoints. So again, these things are really, really hard to interpret. And of course, assessments that we use to measure clinical performance are also need to be validated for that purpose, and a lot of the studies that have been done do not use assessment instruments that have been validated. So that again introduces some bias in the interpretation. So we'll look at some of the studies out there, particularly related to flexible endoscopy. So this one's a green one, meaning that it did show some benefits. And again, these studies have really small numbers. This was done in 1998. 10 novice family practice residents were randomized into practice on a simulator or no practice at all. And basically the simulator group trained for about 6 to 10 hours. And the groups were assessed pre and post, again by non-validated metrics, and they showed that the quality and the efficiency of the exam improved. So again, very small numbers, and as you'll see also, most of the studies for flexible endoscopy have trained on virtual reality platforms, which again are associated with quite high costs. This study was done in 2003 on a different simulator looking at 16 internal medicine residents, and again the practice was self-directed on the simulator compared to a group of residents who received careful bedside teaching. And what they found actually is that the patients the residents who practiced in the simulator actually performed worse than those who had received bedside teaching. And again, the flaw in this study is that there was no structure or guidance for the curriculum, and so clearly it makes perfect sense that the people who did receive careful bedside teaching performed better. And then finally, this is the last study I'll talk about for transfer skills for sigmoidoscopy related, and their outcome measure was really patient discomfort. And they had bigger groups, so 38 people which were randomized, and they only practiced for 3 hours on a virtual reality simulator. But this was in addition to their regular clinical training compared to people who did no simulator but just had regular clinical training. And they used a semi-validated scale that was filled out with patients for discomfort, and faculty evaluations as well. And what they found is that the people who practice in the simulator did cause less discomfort to patients. However, their performance, according to faculty, was no different. So this is sort of some benefit and some not benefit kind of study, all in all. So now we'll move to colonoscopy, which is a little bit more of a complex skill, and there's a little bit more data out there for transferability as it relates to colonoscopy. This was a study done in 2004, and they looked at practice GI fellows. Actually, there was only four residents in each group in this study, and they practiced on the AccuTouch for the first year, first few weeks of their fellowship. And what you can see here is that there seemed to be some benefit, certainly for the first few cases that they performed in the clinical environment. So the very, very early part of their learning curve, they did show some improvement, and that seemed to flatten out after about 30 cases. Again, this study showed some similar results where they had, this is a multi-center trial in 16 hospitals, including 45 fellows, who practiced on a simulator, and again, a different simulator in this situation, unsupervised for the first 8 weeks of their fellowship, and then they recorded prospectively their first 200 cases that they did. And again, we saw some improvements in performance for the first 80 cases, and again, they also looked at patient discomfort in this trial, but that wasn't improved or changed with simulator practice. Another study done in 2007 looked at the impact of a very small amount of simulator practice on clinical performance as well, and so they used a different instrument that they adapted, so an instrument that was designed mostly to measure surgical skills in a laboratory environment, and used very novice endoscopists or internal medicine residents. And they did show that their performance as it was measured by this global tool improved. However, neither group was able to reach the cecum, which makes you wonder sort of about the meaningfulness of it. And this study, recently done as well in 2010, randomized not only doctors, but nurses and then physicians in GI and in surgery in 4 European centers. And again, they used a completely different clinical training, but they had 16 hours of clinical training with a minimum of, you had to accomplish a minimum of 8 colonoscopies within that training, and they used the scope guide for all the colonoscopies. And then they had another group trained for 16 hours on the simulator. So they had equal amounts of time in the simulator or in the clinical environment, and they assessed them at baseline on the simulator. and then assess them clinically on 3 colonoscopies afterwards using various measures that are sort of semi-validated measures of skill in the clinical environment. And they found that the simulator group outperformed the clinical group on the simulator, which isn't a huge surprise. Sometimes it's just dealing with the interface or trying to figure out how the thing works. However, both groups, when measured in the clinical environment, performed the same, suggesting that the 16 hours of practice on the simulator was equivalent to the 16 hours of practice in the clinical environment. And this study was done by a group of surgeons from the Texas Association of Surgical Skills Laboratories on the GI Mentor 2, looking at 41 residents who trained to a proficiency-based curriculum. And they used pre and post tests. So they didn't randomize any of these residents. They just tested the whole group before. And they also tested them in the clinical environment using gauges, which is a tool that we developed as part of the Fundamentals of Endoscopic Surgery program, a validated measure of clinical skills for colonoscopy. And they did show that with this proficiency-based curriculum, there were significant improvements in performance after practice in the simulator. And so clearly there is some benefit to this type of proficiency-based training. So what are the data for upper GI endoscopy? We do see that upper GI endoscopy simulation seems to improve completion. So this study was done with 22 fellows, trained for 10 hours, evaluated by themselves and by faculty, and there was no difference in esophageal intubation or procedure times, but they did have improved completion rates and required less assistance and better overall ratings. So again, really small studies with small numbers of people and small numbers of hours in training, one single event, a training event on the simulator. And so this is the final study that I'll talk about related to upper endoscopy, very recently published in GI Endoscopy, where they wanted to really see the difference between, so they had 3 groups, so 28 residents randomized to 3 groups. One group that received simulation and clinical training, another group that received only clinical training, and another group that received only simulation training. And the simulator curriculum involved a combination of different types of simulators, including some mechanical or physical simulators and a virtual reality interface as well. So this is the only study I found that actually used a non-virtual reality simulator. And they evaluated 3 cases by blinded and unblinded raters in the clinical environment. So what they found is that the participants who had received both simulation and clinical training had shorter esophageal and pyloric intubation times compared to the clinical only, so there was some benefit with the addition of the simulation. The simulation only group had longer procedure times and the lowest scores, so this did not seem to be a great way to do it. And they concluded that clinical training combined with simulation is probably the best way to do it, and that simulation training alone or in isolation is probably the worst way to do it, which makes a lot of sense when we think about learner motivation. So in summary, it seems as though sigmoidoscopy, if we talk about transfer of skills acquired in the simulated environment to the clinical environment, there seems to be some benefit. And again, I think the real problems here have to do with the small numbers, the type of curriculum that was used, the type of training, the type of outcome measures that were used. But there does seem to be some benefit. For colonoscopy, again, there are more studies out there, including more different types of simulators and different methods of training, but again, the data seem to be in favor of the use of simulation for training for colonoscopy. And in upper GI, I think there's same methodologic issues. I don't want to beat a dead horse here, but there are same problems with trying to combine or interpret these studies as a group for a lot of the reasons that have been mentioned already and by some of the other speakers. And we see the themes really are that virtual reality simulators seem to be the ones that people use the most for flexible endoscopy. And the benefit to the clinical environment seems to be added to the simulation added to the clinical training in some way, and whether it's in an iterative fashion, sort of going back and forth between the lab and the clinical environment, realizing in the clinical environment the things that you could work on or get better on and then going back to the lab and working on those things probably is the way to go. So it's a real combination as opposed to a one-shot deal of training on the simulator. You know, it takes time for us to learn things, to actually acquire that level of proficiency or achieve a point where it doesn't require so much attentional capacity as Matt was mentioning, so that this, you know, this actually takes some time. And the current simulators seem to be most beneficial, at least the studies that have been done suggest that it's most beneficial for the very, very novice people who are at the very, very steep part of their learning curve. But again, this may just be also an effect of the interface. Like maybe it's just coordinating, eye-hand coordination and knowing how to hold the scope, and maybe not necessarily related to the actual simulator interface or the exercises or the curriculum at all. It's just maybe spending time with thinking about doing endoscopy that may, you know, have an impact on that. So again, this is just because of the way the studies have been designed up until now. And again, a lot of heterogeneity, a lot of small numbers of people have been tested, and very variable outcome measures that have been used in these studies. So I think that the metrics that we're using need to be better defined for sure to correlate with clinical skills. And we need more standardized and validated measures as well. And so certainly as part of this program, we've developed one called the gauges, which you'll hear about a little bit later. But there are also a bunch of other different things that can be used. And the answer is probably using a combination of all of these different measures, including patient comfort and perhaps including cecal intubation and all of these other things together that in combination can give us some sort of a way of assessing someone's performance in the clinical environment. And again, best practices for training also need to be established, and how do we do this, and what's the best formula, and is the formula perhaps individualizable? Is it different for one person or another? And that I think we're still doing a lot of work for that, and I don't think the answer for that I don't think we have the answer for that yet. Certainly we have a lot of information that we've done from the work with laparoscopic surgery, and I think a lot of that can probably be transferred to flexible endoscopy, but that still remains to be determined. So is it the holy grail or reality? And I think the answer for this, for flexible endoscopy, is really that we're only at the tip of the iceberg. Thank you for your attention.